Welcome to Roadmap to Residency. Hello everyone, I am Abhiraz. Welcome to our Club 250 Mass Maker sessions. We will be running through some questions with you guys to help you on your journey to a 250. And this video is all about diuretics and antihypertensive drugs. So, which of the following is the primary mechanism of action by which mannitol exerts its diuretic effect in this patient? So, a 60-year-old man with a history of heart failure and chronic kidney disease is admitted for acute decompensation. Now, despite receiving standard diuretic therapy, the healthcare team decides to administer intravenous mannitol to enhance the diuresis. Now, during the course of treatment, the patient's urine output increases significantly. So, what is the primary mechanism of action of mannitol in this patient? Inhibition of carbonic anhydrase in the proximal tubule, direct stimulation of the renal collecting ducts, inhibition of sodium reabsorption in the loop of Henle, blockade of aldosterone receptors in the distal tubule, enhancement of water reabsorption in the distal tubule. So the answer is inhibition of sodium reabsorption in the loop of Henle. So mannitol is an osmotic diuretic that primarily acts by inhibiting the sodium reabsorption in the loop of Henle. Now it is freely filtered by the glomerulus but poorly reabsorbed in the tubules. So the osmotic effect prevents the water reabsorption in the nephron, leading to increased urine output. Now these are the different sides of diuretics and their action. So, number one is that the inhibition of water reabsorption, which is done by mannitol, and its act on the PCT. And again, the inhibition of bicarbonate is and sodium is inhibited by acetazolamide, and it also acts on the PCT. And then there we have the loop diuretics acting on the ascending limb of loop of Henle, which inhibits the absorption of sodium, potassium, and chloride. So it is sodium potassium 2 chloride inhibitor. Then we have the thiazide diuretics acting on the distal convoluted tubule, which inhibits the absorption of sodium and chloride. So, and again, after that, we have the potassium sparing diuretics acting on the collecting duct. So, which of the following side effect is most likely associated with the use of acetazolamide in this patient? So, 45-year-old woman is prescribed acetazolamide for the management of glaucoma. After a few days of treatment, she complains of numbness and tingling in her fingers and toes, accompanied by difficulty concentrating and a general sense of confusion. Which of the following side effect is most likely associated with use of acetazolamide in this patient? Hyperkalemia, hypocalcemia, metabolic acidosis, hyponatremia, or hyperglycemia. So, acetazolamide is a carbonic anhydrase inhibitor that leads to increased excretion of bicarbonate in the renal tubules. So, resulting in metabolic acidosis. So, more of the bicarbonate is being lost out. So, the alkali component is being lost out. So there will be metabolic acidosis. The symptoms of numbness, tingling, difficulty concentrating, and confusion are consistent with the acid-base disturbance caused by acetazolamide. So, carbonic anhydrase inhibitor causes self-limiting sodium bicarbonate diuresis. So it decreases the reabsorption of sodium plus bicarbonate, and it decreases the total body bicarbonate stores. So if more of the bicarbonate or more of the alkali is going in the urine, so your urine will be alkaline, and the side effect will be metabolic acidosis. So clinical use is in case of glaucoma, metabolic alkalosis, altitude sickness, idiopathic intracranial hypertension. So side effects could be type 2 RTA, ammonia toxicity, and metabolic acidosis. So which of the following complication is most commonly associated with loop diuretic therapy and warrants close monitoring in this patient? A 45-year-old woman with a history of hypertension and chronic kidney disease is started on torsemide. So furosemide, torsemide, a loop diuretic to manage volume overload. So this question is asking us about the major side effect of loop diuretic: hypercalcemia, hyponatremia, hypokalemia, hypermagnesemia, or hyperphosphatemia. So loop diuretics, including torsemide, enhance the excretion of sodium and water in the loop of Henle, and this increased sodium delivery to the distal tubule leads to the increased potassium excretion, resulting in hypokalemia. Now, therefore, patients on loop diuretics should be closely monitored for electrolyte imbalances, particularly hypokalemia. So again, loop diuretics act on the thick ascending limb of loop of Henle. As we have discussed earlier, it blocks the absorption of sodium, potassium, and 2 chloride. So more of the potassium is in the lumen, and more of the potassium is being excreted out. So if more of the potassium is being excreted out, potassium is leaving the body, and then the patient will be having hypokalemia. Hypokalemia, hyperkalemia, that acutely affects the heart and other. So mainly it affects the cardiac system. So that's why we have to monitor the patient for severe hypokalemia. If the patient goes into severe hypokalemia, then the patient will be having many detrimental effects on heart. It's, so it can be used in case of edematous states, in case of hypertension and hypercalcemia. So another one is the ethacrenic acid, which is a non-sulfonamide inhibitor of co-transport system. Again, just like the loop diuretics, and it also used in the same indication and may have same side effects. So, which of the following is the most concerning adverse reaction associated with thiazide diuretics and warrants immediate attention? So, hyperkalemia, angioedema, hypokalemia, photosensitivity, or gout exacerbation. So, thiazide diuretics, including hydrochlorothiazide, are known to cause photosensitivity reactions. Now, this adverse effect results from an increased sensitivity to the skin to sunlight, leading to skin rash and itching. Now, patients experiencing photosensitivity should be advised to minimize sun exposure and use sunblock. So thiazide diuretics, they have that sulfur group attached to them, so that can cause sulfur reaction. Okay, that can cause skin changes. So that's why they require a close monitoring. Okay, they cause sulfur allergy. So which of the following is the most likely cause of reported breast tenderness and irregular menses in this patient following spironolactone therapy? Hyperkalemia, hypokalemia, antagonism of androgen receptors, increased aldosterone production, and activation of vasopressin receptors. So spironolactone is a potassium-sparing diuretic that acts by antagonizing the aldosterone receptors, leading to the decreased sodium reabsorption and potassium excretion. However, spironolactone also has anti-androgenic effects, which can result in side effects such as breast tenderness and irregular menses due to interference with androgen receptors. So again, spironolactone and eplerenone are competitive aldosterone receptor antagonist. They can cause hyperaldosteronism, which can cause hypertension and hypokalemia. So potassium depletion will be there. Uh, Heart failure, hepatic ascites, nephrogenic DI. So it is used in conditions like hyperaldosteronism, potassium depletion, and heart failure. It can cause hyperkalemia, and it can also cause metabolic acidosis. So potassium sparing diuretics, it is sparing potassium. So potassium is being retained in the body. So obviously the side effect will be hyperkalemia, which can lead to arrhythmia. It is used in case of hyperaldosteronism. Hyperaldosteronism, there is hypertension and potassium decreased. There is potassium depletion in case of hyperaldosteronism. So there's hypokalemia. So if you want to use any diuretic, you would like to use the diuretic that is not leading to the loss of more potassium in the urine. You want to save the potassium. So, and also you want to decrease the hypertension in the patient. So that's why you will use a diuretic that is not affecting the potassium. So in case of hyperaldosteronism, you will use potassium sparing diuretics. Very important concept, because it will also decrease the hypertension, plus it will also not affect the potassium level. Which of the following is the most likely explanation for the dry cough reported in this patient following losartan therapy? Activation of bradykinin receptor, inhibition of angiotensin converting enzyme, activation of aldosterone receptors, stimulation of vasopressin receptors, or inhibition of prostaglandin synthesis. So the most likely explanation for the dry cough reported by this patient following losartan therapy is the accumulation of bradykinin. ARBs like losartan can lead to increased levels of bradykinin, which is not broken down by angiotensin converting enzyme. And the accumulation of bradykinin is thought to stimulate cough receptors in the respiratory tract, causing a persistent dry cough. So angiotensin 2 receptor blocker and alcicrine. So losartan, valsartan selectively block the binding of angiotensin 2 to AT1 receptor. Effects similar to ACE inhibitors, but ARBs do not increase bradykinin. So clinical use is by hypertension, heart failure, proteinuria, chronic kidney disease with intolerance to ACE inhibitors. So adverse effect may be hyperkalemia or decrease in the GFR. Similarly, there is something called as direct renin inhibitor, which can block the conversion of angiotensin to angiotensin 1. And again, the other mechanism is all same. Thank you for watching. keep studying hard.